And then, so first you'll get a Zoom invitation, kind of how Vicki did for her guest speaker for yesterday. It'll be for tomorrow at 2:30, and that's my friend Marvin from Lifelight. He'll be doing your pediatric guest speaker for tomorrow. Did someone say my name? Oh, okay. Never mind. It's the guys that are working outside my door, and he must have been saying my office because he said Chantel, and I thought it was you guys. Trying to get my invitation. Squirrel. Okay. So look for that invitation, be able to log on. It's the ghost of the new building. Yes, it is. And there are a few. I will already tell you. Okay, then so he'll be on Zoom. He's got a great presentation. You guys will learn a lot about pediatric assessment. He's pretty fun to listen to. And then tomorrow night at 11:59 is the pediatric simulation preparation worksheet due. It'll be for sim on Thursday. So make sure that you get that in tomorrow night. And then Thursday for simulation, either from 8 to noon or 12:30 to 4:30, whatever your time is, you'll come to the old building to our sim lab that you've already been in many, many times. And that's where we'll have pediatric simulation, and we'll do all 5 simulations. It's a round robin, so you'll be doing simulation all morning or all afternoon. Then Friday, pediatric simulation will be here in the new building. Yay! So here's a couple of things with that. If for some reason, I am going to put it on Blue Button. Also, if we just have to be kind of careful. So if somebody comes down with symptoms that night or that morning, please don't come in. Please let me know. And we'll just make sure that we've got it on Blue Button so that you can listen and you can get some credit for that. I am also going to require participation from you if you are on Blue Button. So everyone else needs to come in and be in the new building. If you come in the south side doors, so the big main entrance, and come up the big beautiful staircase, you will see Renee's office right in front of you. And if you go to the left of it, there's some big classrooms that are together. So we will be able to socially distance in there. It's actually 2 classrooms separated by a folding wall, and that wall will be folded back. We'll do some pediatric ethics. We'll do some medication math for peds, just to get you ready kind of up to par before you go to primary children's. We will do, I have a guest speaker from Ivy Lane Pediatrics that's talking about respiratory issues and ventilators. A lot of our students go to work as LPNs for Ivy Lane, and he has been gracious enough to say, you know, sometimes they struggle with trachs and vents when they come to us. And so I'd like to come and do a little bit of a presentation and kind of give them some ins and outs so that when, and if they do decide to do some long-term care or some rehab or home care and they have a ventilator patient, they already have some of this information. So that will that is in uniform for both of those, for Thursday and Friday, because it's clinical time. I will send out an email with all of this, or like a Canvas announcement with all of this information later tonight after I get done with pass-offs and stuff for PN1. Okay, I think that's it for all of those. So I have a joke for you. So there's this boy, and he's going to get married, and his dad said, let me give you some advice. He said, on your wedding night, take your pants off and tell her, put these on. And when she tries to put them on and she doesn't fit in them, and they're too big for her, say, exactly, I wear the pants in the family. And as soon as you know that, then we'll get along great. And so he goes and he gets, goes on his wedding night, and he takes his pants off and he tells his new wife, here, put these on. And she puts them on and she says, they don't fit me. And he said, exactly, I wear the pants in the family. And as soon as you know that, we'll get along great. And she said, well, here, try on my panties. So he goes to put them on. He says, I will never get into these. And she said, exactly. And you never will if you don't change your attitude. So there we go. Exactly. Hit them where it hurts, right? All right. Okay, so here's I love it more than words can explain. Thank you, Brooke. You guys are too sweet because that's really hard to tell a joke that you think is pretty funny to an empty office. Okay, pediatric sensory disorders. Very, very short, super simple little lecture here. So I'm not sure why there's a big S on my screen, but our objectives are 5, 6, and 7. Number 5, identify nursing interventions and parent teaching for a child with conjunctivitis. Number 6, identify the clinical manifestations and medical management of children experiencing acute otitis media. Number 7, identify nursing interventions that assist patients with partial or total hearing loss. All right, with conjunctivitis, it's just inflammation of the clear membrane that lines the lid and the sclera. It has many, many causes, bacteria, viral, allergies, trauma and irritants. And so with your bacteria, you're going to notice a different kind of drainage. With viral and with allergies, it's very clear and watery. And with allergies, it affects both eyes. With bacterial or viral, it can affect just one eye or both eyes. But with bacterial, it's thick and sticky and junky, kind of purulent looking. And I'll show you some pictures here. But with the allergies, sometimes people will use allergy eye drops. Sometimes they will just take an allergy medicine like Zyrtec or something like that. With trauma and irritants, sometimes they can end up with a corneal abrasion from rocks or dust. And then other times they get sprayed in the eye with like mosquito spray or sunscreen, something like that that gets into their eyes. And those just need to be flushed really, really well. If it's a significant exposure, then usually poison control can be consulted and they'll tell them how long it needs to be rinsed. For infants that end up with conjunctivitis less than 30 days old, it's usually an STI from mom. And most of the time, a high percentage of them go blind. I have workers that keep trying to get my attention. A lot of them will go blind. And so they need to make sure that moms, that they get a good history on moms before they deliver, because these infants can have a lot of problems with their eyesight. Clinical manifestations, they're red and itchy and they burn. They can have blurry vision. The discharge can be clear or purulent. So at the top, you'll see this guy has kind of a really red eye. That's more viral looking with the clear drainage and the redness. And then the little guy down on the bottom has the conjunctivitis. That is more bacterial when it's thick and sticky and kind of mucousy like that. There's a little YouTube here that shows a physician looking in their eye. I'm not going to pull it up because of our time with me having to kind of mess with my equipment and stuff. Plus, I'm not really sure that it won't drop me and I'll lose you. And we'll have to start all over again. But it does show a pretty infected little eye, and it's pretty short. So you can go ahead and look at that. For treatment and teaching, prophylactic for newborns, many states, so it used to be a federal law that everybody was treated with erythromycin. All the new babies had erythromycin put in their eyes. And now they've given that up to the states. I think it is still at about 34 or 37 states that have laws where they treat all infants' eyes with erythromycin. It's just an ointment. They kind of squirt it in there. It's a little bit goopy. And that will help them if mom had an unidentified STI upon delivery or something she didn't disclose or something like that. First, they will treat the cause. So they have to find out what is causing it before they start the treatment. So if you just have allergies or it's viral and it's not looking like it's bacterial, they're not going to just go and jump and give them antibiotic eye drops or antibiotic ointment. They need to figure out, what's causing it first. Then you want to clean the eye, inner canthus to outer canthus. So start in the center, work your way out with a warm cloth. With that warm cloth, you need to switch sides as you go. So you saw that picture of that little kiddo that has the really junky, sticky eyes. Those are going to need to be wiped several times. And so take the washcloth and start on the inside, go from inner canthus to outer canthus, and then trade to a different part of the washcloth. Make sure you have gloves on. And then go inner canthus to outer canthus, same thing. Change to a different part of the washcloth, inner canthus to outer canthus. And then if they have some drainage in their left eye, then you would want to get a different washcloth because you can transfer. So if they started out viral and now it's in both eyes and one has gotten bacterial and a bacterial infection in it, you can transfer it so easy to the other eye. So make sure that they use a different washcloth. And when you're doing your teaching for your families, make sure that they know to use a different part of the washcloth when they clean, a different washcloth for the other eye, and that they wash their hands really good. And then once they're done with the washcloths, to put it right in the wash with a hot cycle. They don't want to leave it sitting there by the sink for somebody else to come and wash their face and end up with the same problem. With eye drops, make sure you don't touch their eye. The tip of that is sterile and you want it to stay that way so it doesn't contribute to any infection problems. Remove the irritant and rinse it thoroughly. So if they have mosquito spray. So I had my son that was about 10 sprayed mosquito spray on my little guy who was about 4. And he sprayed it. He was like, take a big breath. And then he sprayed it all over his face. And he got it in his eyes. And so, of course, screaming and crying ensued. And we called poison control just to see how long we needed to rinse those for. And they said minimum of 15 minutes. And so we turned on the bath water and we tipped him upside down and just ran his eyes, ran it over his eyes for about 15 minutes. I think the neighbors probably thought we were abusing him as loud as he was screaming. But make sure that they know how long they need to rinse them for. That was much longer than I would have thought. Teach the family that is very, very contagious. They need to make sure they wash their hands very good and teach them about not returning to school or daycare if they're still tearing and discharge, if they still have really junky, sticky eyes and stuff, then they need to not be headed back to school and back to daycare. And I can't see the very bottom. I think it says hand washing. That's the problem with the little screen on the laptop, is you can't always see all of the words. All right. Let's see here. Okay, otitis media. So ear infections. Here's your little anatomy piece of your ear. Out here is your outer ear, right here in the ear canal. Right here is your middle ear. And then over here is your inner ear. And the inner ear is made up of the cochlea and the auditory nerve, or vestibulocochlear nerve. All right, there's 3 functions of the eustachian tube. It protects, drains, and ventilates the ear. So it protects the middle ear from nasopharyngeal secretions. It drains secretions that are produced in the middle ear, and it ventilates the middle ear and equalizes pressure. So little kids have eustachian tubes that are shorter, wider, and more horizontal than adults. So they've got these squishy little short heads, and they've got horizontal, really wide horizontal eustachian tubes. So when they lay back, when they drink, then fluids from their mouth can actually pool back in there and get into their ears and cause ear infections more often. So just remember that they're shorter, wider, and more horizontal. Here's a picture of a tympanic membrane that's healthy. You'll see that pearl gray with a little bit of a light reflex. You'll be able to see those little bones kind of right in behind there, in behind that tympanic membrane. All right, so inflammation of the middle ear is sometimes accompanied by an infection. And I wish I had the guts right now to show this little video. I'm just so unsure of all of our media right now that I would say go ahead and go and look at this little video. It shows a doctor that's looking in a child's ear, and you can see the eardrum is really red and very swollen. When you look at the picture that I've got here, it is so swollen that it's blanching out these little blood vessels. See how wide it is? And it looks very purulent behind there, and like there's a lot of infection. Sometimes they will just see some bubbles, and it's very clear. And sometimes there will just be a little bit of bulging of the tympanic membrane. And so they won't always just give them antibiotics when they see some of those kinds of things. Sometimes they will see them, they will let them see if they can resolve on their own. But if they see an eardrum that looks like this, very angry and red, looks like it's got purulent discharge behind it, it's very painful, it's blanching out these little blood vessels. And also if they're running a high fever, not even really just high fever, if they're running a fever, especially if it's over 100, then they will be more likely to consider antibiotics. They used to say, oh, you've got a little bit of swelling in there behind that tympanic membrane, let's just give you antibiotics. And they did that for a long time. And then it started to be where we found that many of them weren't finishing those courses of antibiotics, which sets them up for super infections, and that we need to be more judicious with how we dole those out. So sometimes if they're not convinced that it's bacterial, they will go ahead and watch them for a couple of days. Most of the time, 6 months to 2 years, these kids get the ear infections. It's usually because they lay down when they drink, and they've got fluids that pool back there in the back of their throat and into their eustachian tubes. And then these kids get sick a lot with lots of stuffy noses from teething, so they have lots of extra mucus and drainage. They're at risk for hearing loss and speech delay if they have significant ear infections, whether it's often or whether it's one big one that doesn't seem to go away for a little while. It can really impact their speech. So clinical manifestations, if they're pulling on their ears, they can have mastoid tenderness, a fever, like I said, right around about 100. If it's more than that, then they definitely know that they need to get antibiotics on board. Bacterial infections generally will cause them to have a higher temperature. Why don't they do just the antibiotic drops instead of the oral antibiotics to keep it more local? They have found in some of the literature that they're not quite as effective because the middle ear, if it's a middle ear infection, it won't get through, like past the tympanic membrane. Now, if it ruptures, the tympanic membrane ruptures, then they can get antibiotic ear drops down there into the middle ear. So if it's a middle ear infection, that's where often they are. That isn't as effective. Does that make sense, Jennifer? But it would be good to keep them more local because the systemic antibiotics, once they have those more and more and more, they can get a little bit resistant to them. So often they will try amoxicillin first. And for kids that maybe that isn't working anymore, they've tried it so many times, then or if they have an allergy to amoxicillin, then they might jump over to erythromycin. And that one makes them sick to their stomach pretty frequently. So if you know that that's what's being prescribed, make sure that parents know to take it with food so that it minimizes that stomach upset. All right, so they can also have poor intake because it hurts to suck on a bottle or a sippy cup and move their jaw up and down and move that tympanic membrane. Sometimes they have diarrhea, irritability, they can have hearing impairment, and then vertigo. Sometimes they are just really dizzy, like they're walking and they just fall, or they won't get up, or they'll seem like they're trying to get up, but they're kind of dizzy like they've been on a merry-go-round. So other clinical manifestations, they can have a really red bulging tympanic membrane, so kind of like this upper left here. Fluid in the middle of the ear, so the bottom right where it's got the little bubbles. They can have kind of an abnormal tympanic membrane. The bottom left is where it's been ruptured. I think that's the one, yeah. It's ruptured. And then the upper right is where you'd want it to be kind of that pearl gray with that light reflex. So here's a normal light reflex and then a displaced light reflex. You can see how it moves when that tympanic membrane has a lot of fluid behind it. All right, so treatments, bacterial infections, they want to treat them systemically, but they will also treat them topically with some steroids. Sometimes that will help with pain with some steroid ear drops. So systemically, they'll give them antibiotics, usually amoxicillin, augmentin, if amoxicillin is not successful, or erythromycin if there's an allergy, a penicillin allergy. Topical steroids, those are really helpful to decrease inflammation, which decreases pain. They used to have some numbing ear drops, which were really pretty great. But then all of a sudden they didn't have them. And I asked my pediatrician when my son had an ear infection why they didn't have them. And he said parents were forgetting to finish antibiotics because the kids seemed to feel better. And so they don't make them anymore. So that was quite some time ago. And I don't know if they've since decided they would make them again, but to my knowledge, they don't make just those numbing ear drops anymore. Analgesics, so making sure that they've got some Tylenol and ibuprofen on board, and then wait and give them symptomatic treatment. So sometimes if there's just fluid bubbles behind there, or if it looks a little bit like the light reflex has been displaced and it's just a little bit kind of swollen, but not really bulging, where it has like that purulent drainage behind it, where it just looks a little bit swollen. Sometimes they'll wait, and they'll just wait a couple days, especially if they're not running much of a fever. Then if the child, they'll tell them if they start to get worse or they start to run a fever or they're not eating and drinking, then let me know and we'll call in some antibiotics. And then they will do surgery often for chronic infections, and they'll put in tubes in their ears. It's called a myringotomy, and I'll show you some pictures here in a minute. And then the bottom, I think it does say myringotomy. Okay. Oh goodness, my thing is cutting out. Hang on a second. My screen is black and my pencil is blinking. Oh, there it is back. I don't know what this is doing. Okay. Brayden, I have tubes in my ears still, because after a few years, they usually fall out. So that's impressive if they're still, it's my 5th set. Oh, bless your heart. Yeah, some people never quite get away from having ear infections that they had as a kid. All right, for your family teaching, slightly elevate the head of their head when they're feeding. So hold them up in their arms. Don't lay them flat, and don't lay them flat in a bed and give them a bottle. Sit them up a little more, like in their car seat or a swing, something like that. No bottles in bed, even with just water. So no milk and juice, obviously, because they get bottle mouth. But even if they have a bottle in bed of water and they're laying flat, they can end up with more fluid back there, backing up through the eustachian tubes. Oh, yeah. When you are born with a cleft palate, eustachian tubes are affected. Very cool to know. Okay. So then what did they say you will always have to have them? Likely. I'm sorry. That's kind of a bummer. Thankfully, it's a very, very simple surgery. And it's not like a knee replacement kind of rehab. All right. Let's see here. No smoking near the child. It can I don't know the research behind how it makes them more prone to ear infections, but there is literature and research that shows that they are more prone to ear infections if they are around someone who smokes. And then, oh, they can just place them in the office. Oh, very cool. We used to just go to a little same day surgery, and they would put their tubes in. So that's kind of nice that they just do it in the visit at the office there. Control their allergies. If they have significant allergies, and there's Claritin for kids, there's Zyrtec for kids. I don't know about some of the others, but they can also give them some Benadryl, and that can help control their allergies, and they won't have as much mucus production that can cause more ear infections. They need to finish their entire antibiotics for sure, even if their child feels like, or it seems like they're feeling a little bit better. Soft foods, warm packs, and cold drinks. Cold drinks can kind of numb things from the inside. Warm packs can help with that mastoid tenderness. And then soft foods just make it easier to chew so they're not working so hard and having their ears hurt when they're chewing. Acetaminophen and ibuprofen, never aspirin for the risk of Rye syndrome. Schedule follow-ups with hearing tests as advised. So if they are showing some speech delays or more problems than just an ear infection, then they need to go and get their hearing tested. And I think this says otitis media. Can't read it. And last time I went into this full screen was when my screen blitzed out again. So I'm not going to do that again. Somebody tell me what it says on that last line besides otitis media.
It says that it's not contagious.
Okay. Do you guys still see my presentation, or do you see a black screen?
We can still see it.
My screen is black, and my pencil is blinking at me. I'm not sure. Oh, there we go. Okay. I'm not sure. When I try to go bigger on my screen, then it keeps kind of fritzing out. So we won't do that again. With a myringotomy, this is where they place tubes for the treatment of chronic otitis media. And they just look like this little tiny green tube here. And you can tell when if you look in their ears, sometimes if they've had tubes and they've fallen out, they have a little tiny white spot where the tubes were in their ears. So post-surgical education for a myringotomy, avoid straining with a BM. So if they're a little bit older and you can tell them not to push when they have to go to the bathroom, then make sure you pass on that education. If they're a tiny little one, then one thing that I would tell family members is to make sure that they just give them maybe an ounce of juice twice a day. It kind of loosens things up, and then that helps them avoid straining. Don't drink through a straw up to 2 to 3 weeks. That's a little controversial. Some physicians say, oh, it doesn't matter. Others say it does, and that you can pop those tubes out of there. So just make sure that you are giving the education. If you are giving discharge instructions, make sure you're giving what the physician wants you to give. And you can even just tell them to err on the side of caution and tell them sometimes straws can cause some problems with new tubes and them possibly falling out. So if they can avoid a straw, it would probably be better too. Blow their nose gently, keep their ears dry so they've got good earplugs, not the little foam ones that you use when you go, shooting guns, or when you're trying to sleep and not listen to the rest of your family or the noise outside. But there are some really good, they have wax ones that are really pliable and they go in their ears. They have gel ones. I'll show you some pictures here in a second. Report any excessive drainage or pain over 2 days. So they shouldn't be very painful. And a fever greater than 101. So if they shouldn't run a fever at all. And so if they're running a fever over 101, they definitely need to let the physician know. And then a complication can be mastoiditis. And so then they would end up needing antibiotics for that a lot of the time. So here's these little aqua ear bands. Those fit in their ears very nicely. They need to make sure they wear them when they go swimming, especially if they're going into like a lake or a river or something like that, to keep that dirty water out of their ears. Some people that have had tubes in their ears say, "Oh, I let my child swim without them. It's just fine. He's never had a problem." But I always taught my families that to try and keep that middle ear as dry as they can to minimize ear infections, than to make sure that they put earplugs in their ears. All right, conductive versus sensory neural hearing loss. Just learned about these now. What do you mean, McKenna? Just learned about the earplugs? Oh goodness. Yeah. So when they go to have a bath or something and you're washing their hair, you just try to keep the water out of their ears the best that you can. But if they go swimming, it's good to put earplugs on them. Conductive versus sensory neural hearing loss. So conductive hearing loss is going to be out here in the outer ear. Let's see, red doesn't work there very good. Let's try blue. Blue, outer ear, and middle ear. That's conductive hearing loss. And then in here in the green is sensory neural. So sensory neural includes the cochlea and the vestibulocochlear nerve. With conductive hearing loss, conditions in the external canal prevent sound from reaching the middle ear. So it can be an outer ear infection like swimmer's ear. There can be some trauma, a foreign body in their ear. So if you have a child that normally hears just fine, they have good speech, they do just fine, and now all of a sudden they seem to not be in any pain, but maybe all of a sudden not be able to hear very well, then they might have a bean in their ear. And I'm just speaking from experience because I have boys and they stuck beans and beads and all kinds of things in their nose and their ears. And so just make sure that if family members say, it seems like they're not listening or they don't hear me as well, that maybe that's something you consider. And then they can have some impacted cerumen or earwax. Onset might be fast or slow, and it might be temporary. So with conductive hearing loss, so outer ear, middle ear, conductive hearing loss can be temporary. And it affects all ranges of sound. So it can be just low, it can be just high, it can be both. And then hearing aids might help. Hearing aids just amplify sound. So if there's sound there and the cochlea and the nerve and the brain are processing that sound, then you can amplify it with a hearing aid, but only in conductive hearing loss. With sensory neural hearing loss, it occurs when the hair cells in the cochlea or along the nerve pathway are damaged. It can be congenital or acquired, and this is where they say if you listen to music too loud, then you're going to damage your hearing. They're talking about these delicate little hair cells inside the cochlea. It's permanent hearing loss. It's unresponsive to medical treatment. So sensory neural, once it has affected those little hair cells in the cochlea or affected the nerve, then it is permanent. And then cochlear implants might be helpful, but hearing aids do not help. You can't amplify sound when there's no sound being processed or being recognized by the cochlea or by the nerve. How come they make people with sensory neural hearing loss try hearing aids before getting implants? Oh, because I think they want to make sure before they do cochlear implants, they're terribly expensive. And there's a lot of risks with them that they want to make sure that it isn't something that is conductive hearing loss before they go to all of the other extreme treatment measures, I guess, for sensory neural hearing loss. Good question, Victoria. Implants can make it so that you can hear, but it's different. They have to relearn how to interpret sounds. Very good. Very good. That is a good segue to, I think it's my next slide. Oh, no, I'll come back to that. It's more of a mechanical stimulus. Yes, it is. And so I will come back to that at the very end, but you're exactly right, Braden. With clinical manifestations, mild to moderate, sometimes it's undetected until preschool or kindergarten. If they're having some hearing loss, but maybe it's not profound. Certain reactions or mannerisms to observe, inability to locate a sound. So if somebody slams a book down, they should turn right toward where that book is. But maybe they look around because they heard something, but they can't identify the direction that it's coming from. Turning their head to one side when they're listening, like they're trying to listen with their good ear. They might give inappropriate answers to questions, so if they didn't hear you very well, and they can't whisper. And so little kids, sometimes when you say use your quiet voice or whisper to me, and they don't whisper. They don't seem to be able to talk quiet enough, because then they can't hear themselves and they're not sure that they're talking. So they talk loud enough that they can hear themselves, and then that can be a good indicator too that there's some hearing loss. Oh, I see. That's how you knew that, Victoria. Okay. So your little sister is deaf and thought that it was so dumb she had to try hearing aids first. Yeah, I think they want to make sure before they go to the great lengths of cochlear implants and things like that, to make sure that they don't have some kind of hearing that can be amplified. So this little boy has a hearing aid here. I think it's Ninja Turtles. Do a really good history and assessment. Ask them about their vocabulary, and ask parents when they started talking or how well they talk. Listen for a speech impediment when the child talks to you. And they need a complete audiological assessment by an audiologist if there's any question of possible hearing loss. And then educate the parents on early entry preschool. Early intervention is a key. I can't stress that enough. Early intervention, early preschool. Get these kids in there, get them working with people who know and understand how to help them, to keep them on par, so that when they get ready to go into preschool or kindergarten, then they're able to be caught up with the other kids their age. So early intervention. And then hearing aids can be helpful for conductive deafness only. It only amplifies. I had to try and read over the edge there. So hearing loss nursing interventions, stand or sit face to face on their level. Make sure they see you before you touch them. So don't come up behind them and put your hand on their shoulder. Come around them and let them see you so they're not startled. Speak clearly and at a normal rate and volume. So normal rate and volume. Don't yell at them, obviously, but don't try and talk really slow. I have a really good friend, Lacey, who has lost her hearing throughout her life, and she only hears a few very low tones. And so when you're talking to her, she does a large amount of lip reading. She does have hearing aids that she wears on one side, but she lip reads really well. She said the only time that it's really hard for her is when people try to talk and enunciate like that. And it's very annoying, and it's very hard for her to understand them. So don't do that. Let's see, and speak in very short sentences. So give them just simple little things, really short sentences, and don't, avoid long explanations of things. Assess for understanding. So make sure that you have, kind of like when you're discharging somebody from the hospital and you want a return demonstration, and you want to make sure that they understand the discharge instructions. Make sure that you have them show you or tell you some way that you know that they understood you. Allow them some extra time to respond. Demonstrate procedures as often as possible so that they can see what's done and they don't have to just rely on their hearing. And then again, early intervention is the key. Another good nursing intervention is to capitalize on other senses because they have such a hard time hearing, whether it's conductive or sensory neural. So whether, even if they're wearing a hearing aid, sometimes background noise can make it a little difficult to hear. And so using their sight, using demonstration, using smell, capitalize on those other senses and teach the families to do the same too, because they really rely on their other senses. All right, cochlear implants. I thought this was the cutest picture of his tattoo to match hers. There's a little video here about cochlear implants, but I'm just not trusting my media enough right now to go and show that to you. Sorry for missing all the videos and stuff. They kind of make it a little more interesting than just a lecture. Okay, cochlear implants. So it's an external speech processor, and it captures ambient sound and converts it into a digital signal. The signals are transmitted to an internal implant under the skin, and the implant converts the signals into an electrical impulse, which is sent to an electrode array that's inserted into the cochlea. So you can kind of see up here toward the top how it comes from the external part of the ear here and kind of comes down, and then it'll come in right into the cochlea and kind of wraps right in through there. The links are right here, Mark, on the videos, or on the slides. So each one of them that are YouTube links and stuff like that should be right there. No, and that's okay. That's okay. We all have those moments. It's all good. Anyway, so it creates more of a. My friend Lacey, who doesn't hear well, her husband has had sensory neural hearing loss. It was congenital. He was born that way with both ears, and so he hasn't heard ever until he was an adult. And he decided, as his children were growing up, that he wanted to be able to hear them. And so he got cochlear implants. And he said it was a very difficult transition at first. You're so used to this life of silence. And then all of a sudden you can hear, and even just the slightest noise is almost deafening. It seems so loud. So they can have the volume turned way down on there just as they're getting used to it. And it sounds like a tin can almost. It's very metallic sounding. And yes, and it probably gave him headaches. He did have some headaches. And it has taken some time. He would wear one, and then he wouldn't wear them for a couple of days, and then he'd wear both, and then he wouldn't wear them for a couple of days, and until he got better and better and better and was able to turn up the volume a little bit and be able to function with them. But even now, some days, if he already has a headache or he's already not feeling very well, he won't wear them because it does contribute to a lot more to process, a lot more for the brain to process. And so sometimes he'll still opt not to wear them. So pros and cons of cochlear implants. You would think, and until I met Lacey and actually knew other patients that were deaf, I thought pros were really all that there was for them, because who wouldn't want to hear, right? I love music and playing the piano and singing and stuff like that. And so I thought, a life without music might be really, really tough. But then as I got to know some people that were deaf and talked to my friend, she said there's actually more downsides than just the risk for meningitis. So with pros, they have the ability to hear emergency alarms and hear conversations and be a part of things that way. And some of the cons, I'll jump to the second one here for a second. Expense. They're extremely expensive and not generally covered by insurance. They can be paid for with flex and health savings, but they're thousands and thousands of dollars. And then a risk for bacterial meningitis. And so most of the time they won't do cochlear implants anymore without meningococcal meningitis, and I believe pneumococcal meningitis vaccines. The Hib meningitis isn't one that's as big a risk, but pneumococcal, meningococcal meningitis are a risk for patients with cochlear implants. And then there's this thing called a deaf culture. So when you think about somebody who's raised in a certain culture, then there's certain things that they're used to, certain things that are important to them, certain ways that they behave or that people around them behave or how they treat them. And so they're raised with this deaf culture. And then they go and get cochlear implants, and all of a sudden they're not deaf anymore. All of a sudden it's kind of a culture shock. They've kind of moved. It's like going to a foreign country and being way outside your realm and not having, you're experiencing things very different. Also, some people who are deaf don't look at it as a disability. They work, they have families, they do all kinds of things that are very, very normal, and they don't look at themselves as disabled. So when someone pipes up and says, why don't you get cochlear implants, then it's almost offensive. It's almost like somebody's saying, you're impaired when you didn't think that you were, or that you have a handicap when you didn't feel like that you had any handicaps. So, and then also some people will be shunned. So if they have a family member that's deaf and they are deaf, and then they go and get cochlear implants, sometimes that other family member isn't happy with them, and they'll end up not having a very as good of a relationship. So just know that there are lots of things that go into play besides just the pros of being able to hear. I think that's the last slide for this lecture. So I apologize that we didn't get some of the videos in there. I would say go and look at them. They're just short little clips. Some of them have a timestamp with them. So just watch in that little time period, because sometimes it's a longer video, but it just has a little clip of what is helpful. And then I think I gave you all of our announcements about the next few days. Now that I'm done just a little bit early, I'll probably try and go ahead and draft a Canvas announcement, just going over the next few days, so that you guys have that as a reminder. And then I will see you in Peds Sim on Thursday. Come ready to play. That is a fun, fun day. If you did your Peds Sim worksheet last week or the week before, whatever, make sure that you just kind of do a quick little brush over, like 15 minutes. Just look through it so it's kind of fresh in your brain, so that you can go into these simulations prepared. Any questions about what we talked about? No? It's pretty straightforward. This is a Peds unit that is really straightforward. Okay. All right. Well, I will get this announcement out to you guys, and I will see you Thursday. Have a good rest of your day. You are welcome. See you later.